Hi, everyone. Welcome to the Cal Hospital Compare webinar on the nuts and bolts of dispensing naloxone. This webinar is being recorded. Next slide. So we're proud to offer continuing education credits. There will be instructions on our website on how to claim the CME credits after this webinar. Next slide. So we have some tips and tricks about using Zoom. Number one, all lines are muted upon entry and you're able to unmute yourself as needed. But the key takeaway on this particular slide is that you have the capacity and capability to utilize that nifty chat box. So if you haven't already, click that chat box icon on your toolbox and select to all panelists and attendees. That way, everyone in the chat can see your responses. If you'd like to access the slides for today's webinar, my co-facilitators will be sharing a link in that chat box for you. So another reason to utilize that chat box. Next slide. So we have a number of meeting objectives today, but the one that I'm most excited about is hearing from two hospitals how they've implemented a naloxone distribution program. Next slide. So this is just a friendly reminder that this webinar is actually part of a 5-part series to support the Opioid Care Honor Roll and Self-Assessment. So each one of these webinars is actually tackling one piece of that self-assessment tool, because guess what? I want everyone to make the Opioid Care Honor Roll. Next slide. So this webinar is offered by Cal Hospital Compare. We are a nonprofit organization dedicated to providing Californians with actionable data on where and how they can receive their care. Next slide. So the hosts for today include myself, Alex Stack. I'm the Director of Programs and Strategic Initiatives with Cal Hospital Compare. I'm joined by Amy Moulin. She's the Co-Director for ED Bridge and the immediate past President for Cal ASEP. I'm also joined by Steve Tremaine, and he's our Resident Physician Improvement Advisor. Next slide. It is my pleasure to introduce our guest speakers for today. Firstly, Josh Lustig. He is the Regional Director for California Bridge. He is also the Project Manager for the Naloxone Distribution Project at Highland Hospital. Curtis Geyer is the other guest presenter today, and he is a pharmacist at SF General. Thank you so much for taking the time to join us today, and I cannot wait to hear more about the program that you developed. So enough about me and the guest presenters. I want to know more about you on the call. So what excites you most about working on opioid safety? So take a second, respond to the poll, and I want to know what you have to say on this. All right, I'm seeing some of those responses coming in. Okay, let's share back those responses to the crowd. Thank you. So guess what? What excites you most is about saving lives. And you know what? Me too. I've always been I have so much passion for this work, and I'm so proud that we're all here together collaborating on how we can do that. Next slide. So now I'm going to transition and talk about the Opioid Care Honor Roll. And I'm sure those who have been part of the webinar series to date might be thinking, wait, I haven't heard this before. So since we last spoke, we've actually changed the name from the Opioid Safe Hospital designation to the Opioid Care Honor Roll, partly because there's been so much excitement and so much discussion about this across hospitals and other stakeholders. But there's also been some feedback from this same group saying, guess what? You know, the other one was a little confusing, and having it listed as the Opioid Care Honor Roll makes more sense, not only to consumers, but to our hospitals as well that might be receiving the honor roll. Next slide. So as part of this program, there are a number of key questions that have been arising, and I have a couple of them listed for you here. You can always access the full FAQ on our website, but I'm going to spend some time talking about this first one. What is the value of applying and attaining the Opioid Care Honor Roll? And firstly, it's because guess what? You get to celebrate the work that you're already doing. You get public recognition for that. You are saving lives. And we're really proud to partner with a number of stakeholders to help promote the honor roll. And in addition to that, we'll be partnering with the Secretary of California Health and Human Services, Dr. Mark Ghali, and he's on board to also promote this as well. And guess what? This is a well-deserved recognition because this is a collaborative effort, and we want to be able to recognize that across California. So next slide. So, as I mentioned before, this is actually something you have to actively apply for. So the countdown is 23 days until September 18th when those self-assessments are due. And if you have any questions about how to do that, check out our website or email me day or night. Happy to help you walk through that. Next slide. So what is your current progress to goal? Where are you in applying for the Opioid Care Honor Roll? So let's start that poll. So take a second to respond there. Oh, I see lots of responses coming in. Thank you. Okay, all right, let's share those back. Okay, so it looks like the majority of you haven't started. Well, please do not delay. This, most people tell us that it takes about 60 minutes to complete this, but you want to be able to do it with a team. So schedule that time now to get working on that self-assessment tool. And thank you to those who are already in progress and or have submitted them to us. Thank you. Next slide. So now I'm going to turn it over to Amy Woolen, and she's going to really bring it home why we're here today.
Thank you, Alex. So this is one of the parts that actually I'm most excited about because this is about saving lives. And why we started on this is about saving individuals who are dying from opiate use disorder. And so these are some comments that are from actual patients that we pulled from the HOPE network. And I really just wanted to draw your attention to the third one. And this is from a patient whose life was actually saved. And this is from their mother, where she said, "I suddenly awoke to frantic screams from my son that something was wrong with my daughter, Callie. I ran into Callie's bedroom and I saw the most frightening sight ever. My daughter appeared to be dead." And this is a girl whose life was saved because of access to naloxone. So I just wanted to reinforce the point of why we're here today, and that is to increase access to a really, truly life-saving medication. So thank you very much for all participating on this. Next slide. I also wanted to bring it back, take a big picture on where we are in our opioid safe self-assessment. Remember, we went through the 4 domains, and here we are in our 3rd domain, which is overdose prevention. And that is the piece around naloxone education and distribution. And what we're really going to drill down today is how to get this life-saving medication into the hands of patients and family members. Next slide. So I want to talk about where you are today and what level best describes your work around overdose prevention. And we'll go ahead and put that poll out. Do we want to go ahead and show the results?
Sure, I'll give them just a few more seconds here and then we'll share.
Great, so it looks like a lot of you have protocols out there for distribution. I'm kind of excited because that's more than I expected, so well done, everyone. We're going to talk today about how everyone can do this and make this more accessible to our patients. And Alex, I'll turn it back over to you.
Thank you. I had myself on mute, and it took me a second to realize that. Well, without further ado, I'd like to turn it over to Josh and Kurt to really talk about their program and what they've developed. So Josh, take it away.
Hello, and thank you. And first off, I would like to thank everyone for joining us to discuss the important topic of high-impact naloxone dispensing from the emergency department. And also to thank Curtis for being here to offer his expertise. I have no disclosures to make. Can we go to the first slide? Okay, and next slide. So why dispense from the ED? People who are at high risk for overdose frequently use the ED for healthcare. One closed response survey found that 11% prevalence of people who inject drugs among our ED patient population. If you have an ED volume of, say, 65,000 patients per year, and you multiply that out by 11%, you get 7,150 patients. Then you start counting those who use opioids via other routes, like taking pills, or those using stimulants that are being contaminated with fentanyl. Then you start counting their family, their friends, and you get maybe 2 times, maybe 3 times, maybe 5 times that number, maybe more. Are we at half of our 65,000 people visiting the ED annually yet, or more? EDs in the waiting rooms of EDs are an enriched environment for high impact dispensing. Next slide, please. So you may be thinking, we've already got this covered. Let's do an audience poll. What is your current process for distributing naloxone at your hospital? Okay, can we get the results? Okay. So prescribing seems to be the most popular choice. And that's true at our institution as well, prior to implementation of this program. So my question is, to everyone, is would you consider these high impact interventions? Let's look at those numbers. Next slide. Yeah, this slide. Despite being a covered benefit for most health plans, prescription fill rates are very low. One study found that for patients at risk for overdose, only 11% received an naloxone prescription. And only 1.6 of those at risk actually filled their prescriptions. This is a dismal number. There's other processes that can be put in place. They also have incredibly low fill rates. The typical current process for an ED pharmacist filling naloxone prescription and delivering to a patient in the ED as an alternative process has even lower impact because it needs a clinician to identify a patient at risk, be aware of this alternative process, and have an ED pharmacist available to fill the prescription and deliver this to the patient. There's also the process of pharmacist furnishing. That's likely an even lower impact. One study found that 2 years after implementation, only approximately 1/4 of California retail pharmacies were furnishing naloxone to patients without a physician prescription. Reasons for the practice not being implemented may include lack of knowledge of the legislation, lack of required training, stigma about substance use disorder, and time. The common theme is they're all underutilized, complex, and having limited impact. Next slide. Problems with the current process. They're underutilized. Most potential recipients are never identified. They rely on highly trained licensed staff being involved who have limited availability. There's unneeded steps and barriers. Each step adds waste, inefficiencies, opportunities for failure. The low-value process. Few actual naloxone kits end up in the hands of the at-risk population. It's an ineffective response to the opioid crisis and the national public health emergency. And the bottom line is we're not meeting the aim of reducing the fatal overdose rate in our community. Next slide. Let's focus on that goal. Reduce the fatal overdose rate with naloxone in the hands of those at risk for overdose. Next slide. The path to actually reducing that fatal overdose risk, we need to focus on the value-added step, which is naloxone in the hands of those at risk. We need to eliminate waste. All non-value-added steps have to be eliminated. And we need to create an army, enlist lay people and staff of all types to engage in identifying eligible recipients and help distribute and educate. Be efficient, create a streamlined workflow for lay staff to deliver naloxone, minimizing the impact on other patient care-related activities. We want to include visitors so family and friends of those at risk can receive naloxone. We want to allow anonymous dispensing to overcome the stigma and shame associated with opiate use disorder. And we want to make dispensing available on demand 24/7. Next slide. So where is a model we can look to where naloxone dispensing is done really well, simply and efficiently? Libraries. California state law, Department of Healthcare Services, the Board of Medicine, the Board of Pharmacy, the Surgeon General, the public, everyone supports dispensing in this simple way. These librarians are non-clinical staff who have basic training in naloxone and naloxone dispensing and are making an impact in their communities. This is an example of how the state of California is following the Surgeon General with an the Surgeon General's guidance with an all-hands-on-deck approach to get naloxone in the hands of those at risk of overdose. This has revolutionized how naloxone is distributed. No longer is it locked away in pharmacies. Instead, in the face of an opioid crisis, a militia of lay people is being enlisted to create a broad-based distribution workforce. This means librarians, taxi drivers, lifeguards, full citizen distribution. Next slide, please. So the solution is to build a simple, efficient, and effective model of dispensing in the ED from the ground up. This is Highland Hospital in Oakland, California, where we've implemented a high-impact model of dispensing since April 2019. Let's walk through how we did it step by step. These are the steps. Step 1, you need to issue a standing order. Step 2, create a standard operating procedure. Step 3, apply for a block grant for free naloxone dispensing. Step 4, create a very simple workflow. Step 5, enlist your entire workforce. Next slide. Step 1, the standing order. Standing order is issued under section 1714.22 of the California Civil Code. This is legislation developed in response to the opioid crisis. It permits a licensed healthcare provider to issue a standing order for the distribution and administration of naloxone. This legislation allows your staff to carry and dispense naloxone. Next slide. This means all staff who want to participate. That includes nurses, volunteers, ED techs, social workers, resident physicians, PAs, NPs, pharmacists, registration clerks, financial counselors, security guards, and most importantly, substance use navigators. Everyone who undergoes training can carry naloxone and dispense naloxone kits. Next slide. This is an actual example of a standing order drafted in accordance with section 1714.22 of the California Civil Code. Creating one can be easy as downloading a template, putting in your information, and making any modifications you see fit. Next slide. Step 2 is to create a standard operating procedure, or SOP document. You can draft it so that it identifies your project background, target population, purpose, procedures, and process. You'll want to collaborate with your pharmacy department, but have the clinician who issues the standing order, AKA the project director, direct and supervise the dispensing program. Next slide. You want to ensure that all elements of the naloxone dispensing program will be under the supervision of the clinician who issues a standing order. That includes protocol development and implementation, receiving naloxone shipments, naloxone storage, the dispensing process. This creates a clear delineation between naloxone dispensed under a California Civil Code section 1714.22 standing order and all other medications in your institution. Next slide. Again, this is as easy as downloading a template, making modifications, and putting in information specific to your site. This is an example of the standard operating procedure. It's just a 2-page document. You want to keep it simple. Okay, next slide. Step 3 is to apply for free naloxone. So the Naloxone Distribution Project, or NDP, is funded by SAMHSA and administered by the California Department of California Department of Healthcare Services, DHCS, to combat opioid overdose-related deaths throughout California. And yes, that is a picture of Dr. Andrew Herring sitting on crates of naloxone received from the NDP. Next slide. The program requirements of the NDP are straightforward. The only reporting requirement is that, quote, if known or available, you need to maintain and report the number of reversals that occurred using the naloxone distributed under this application. That is a difficult number to obtain and may not be known or available in your emergency department. Naloxone efficacy is tracked through a saturation model. So doses out is actually a better indicator than reported reversals for efficacy of your program. Naloxone must be provided free of charge, and only simple inventory control is required, for example, maintaining log sheets. Naloxone must be stored separately from medication used to treat patients. Some examples are regular cabinets and keeping a reserve supply in the program director's office. Next slide. So you can find this program by Googling DHCS Naloxone Distribution project. And when you get to that website, you're going to want to click on the Apply for Free Naloxone tab. Next slide. And you'll encounter a very simple form that is a simple sort of one-page application. Next slide. Some of the things you will need to some things you will need to fulfill the terms and conditions part of the grant. You'll need to talk to your hospital administrator to find out your institution's FBIN number, the business license, or tax-exempt letter. You already have your standing order from step 1, so that's taken care of. You will need to ignore the link to the CDPH standing order, as that standing order is for locations that do not have a physician available to issue a standing order. And if you have completed the SOP from step 2, this can provide your, quote, brief and comprehensive summary of your program. Next slide, please. The next step is to click on the NDP information and FAQ link. Next slide. On this page, you will need to make sure that your standard operating procedure includes the items listed on this page. You're going to follow the next link to the Naloxone Terms and Conditions form for emergency departments. Next slide. For the TNC form, they ask 2 questions. 1, they want to know the address of your storage location, which is the actual physical address of your hospital. And 2, they want to know that the NDP naloxone will be kept separate from medications in which reimbursement will be sought, i.e. kept separate from all other medications used at your institution. Examples of storage locations that fit this criteria include, again, cabinets, as in the photo on the left, and the office of the program director, as in the photo on the right. And that's a picture of Christian, our lead substance use navigator, admiring the boxes of naloxone filling Dr. Herring's office. Next slide, please. So step 4 and step 5. Step 4 is to create a very simple workflow. An example of this is 1, sign the log sheet. 2, give kit to recipient. 3, show instructions to recipient. And then step 5 is to enlist your entire workforce. Next slide. One way to do this is to turn your storage cabinet into a self-help naloxone dispensing kiosk. On your cabinet door, you can have instructional posters and log sheets. Inside the cabinet, you can store boxes of naloxone. Next slide. On the left is an example of an instructional poster on the cabinet door. It details who can receive naloxone kits, who can dispense kits, how to dispense, and why to dispense. In the who can dispense section is a link and a QR code that connects the user with the standardized 11-minute training video produced by the California Department of Public Health that is high quality and meets the requirements of the NDP program. This video can be viewed on any device that can connect to the internet, including any smartphone, phone, or computer terminal. This training video can also easily be incorporated into annual competencies training for all staff. Anyone who watches a training video can dispense naloxone. Next slide. It can also be helpful to include a simple summary instruction sheet for those who have already completed the training video and just need a reminder of the required steps. Step 1, complete the dispense log on the cabinet door. 2, review the instructions on the naloxone box with the patient or visitor. 3, for patients, the electronic health record note, quote, naloxone and overdose education provided. Of course, you can also build templates for documentation into your EHR. Next slide. It is helpful to have a folder in the storage area that contains log sheets, as in the top picture. And to design your log sheet so that key elements of the dispensing program are integrated into the log sheet. This includes having the user verify that 1, that they reviewed the instructions with the recipient, and 2, that they have completed the training video. This log sheet takes just a few seconds to complete. Next slide. Depending on the kits received through the NDP, you may have the instructions as a flap integrated with the naloxone packaging as pictured. This makes things really easy. Brochures are also available. Naloxone use and overdose response education typically takes less than 5 minutes. Next slide. The To assist those that want to set up similar programs at their institution, we are making examples of all the documents discussed in this webinar available at these locations: calhospitalcompare.org, bridgetotreatment.org, and harmreduction.org. If you have suggestions on how to improve these resources, please email info@bridgetotreatment.org. Next slide. Okay, so you've suffered through the administrative portion of how to get this type of program going. Let's talk about impact. Prior to implementation, in all of 2018, we had 320 prescriptions written, which resulted in 88 prescriptions filled, representing 7 kits in the hands of someone at risk for overdose per month. If you look at the numbers at your institution, you may find your number of kits in hand are similar. Bear in mind that naloxone efficacy is tracked through a saturation model, so doses out is the best measure of efficacy. Let's see what happened when we adopted this new model. Next slide. Our dispense rate skyrocketed. Can we go back a slide? Our dispense rate skyrocketed. Program inception was April 2019, so we are basically 5 months into our program. In those 5 months, we have directly dispensed 1,512 naloxone kits. This represents 302 kits in the hands of someone at risk for overdose per month. This amounts to an astounding 43-fold increase in our dispense rate. That translates into lives saved. This low barrier distribution method is similar to the way syringe services programs dispense, and they account for the most saturation and reversals in California. Next slide, please. Positive ripple effects. So this innovative process of large-scale, low-threshold dispensing of in-hand take-home naloxone to patients and visitors was implemented as a countermeasure to existing naloxone provisioning mechanisms that were wasteful and inefficient. The energy and excitement surrounding this new program has now catalyzed change in our community, sparking the creation of an interagency partnership with Oakland Police Department, with plans being made for OPD homeless outreach teams to join us in dispensing naloxone dispensing directly to the public. Next slide. So why is this working well? How did we achieve such a dramatic increase in our dispense rate? Let's recap the key elements of how we got there. We focused on the value-added step that benefits our patients and our community. Those at risk for overdose, their family, their friends, leave the ED with naloxone in hand. We eliminated waste. All non-value-added steps were eliminated. We created an army. Lay people and staff of all types engaged in distributing in the enriched environments of the ED and the ED lobby. We became efficient by creating a streamlined workflow for lay staff to deliver naloxone, minimizing the impact on other patient care-related activities. We allowed anonymous dispensing in order to overcome the stigma and shame associated with opiate use disorder. We provided naloxone for free without copay. We made dispensing available on demand 24/7. Next slide, please. Additionally, naloxone signage, storage in the ED, and physical kits being passed out are visual cues in the environment, continually reminding all staff to dispense and increasing awareness among staff, patients, and visitors regarding the importance of carrying naloxone. As a result of these factors, we are going to have a much bigger impact on the overdose fatality rate. Next slide. So, in conclusion, in the context of an opioid crisis, a simple and efficient, all hands on deck model of dispensing naloxone in the ED via standing order is an appropriate and effective way to decrease the overdose fatality rate. Thank you.
Hi, Josh. This is Alex. Wow. Just wow. Thank you for walking us through how you developed this amazing program. And you kind of made it super simple, which I know that it's not. So that took a lot of work to be able to do. Now, during your presentation, there's been a ton of questions streaming in from our audience. So I'd love to really recognize those and ask you if you could respond to them. So one of the first questions that we got was one of the folks on the line was, our feedback from the Board of Pharmacy is that without a hospital dispensing pharmacy, dispensing of naloxone is not allowed. So what would you respond? What might you say?
So yeah, so the model that we're working with is rather than having this the entire program is run with a standing order issued by the healthcare provider so the healthcare provider who is issuing the standing order supervises the entire program. So this is not a program run by the pharmacy. This is run directly by the standing order issuing physician. And your standard operating procedure creates the way it's written and the way the California law supports this method of dispensing in that regard. And I would also, this is the other thing. Just sort of zooming way back. This process is a very simple process that is supported by the state of California and has on many levels. And basically, what I would like to do is take those types of, there's basically a lane is created through the standing order that separates this process from all the other processes and all the other medications that are coming out of your institution that follow the rules and the Board of Pharmacy rules that are created for those medications. This, by using the standing order process, is an entirely different system, and as such is not governed by those rules directly. But those are great questions and definitely should be taken offline, and we will Curtis and other experts in this area we'll discuss those sort of ins and outs of those details. But that's sort of the big picture.
Hey Josh, if you don't mind, I'd love to just tag on. I think as a pharmacist, I think one of the major considerations everybody has when adopting a program like the model at Highland and the model we have at CSFG is consideration of pharmacy regulations. And like Josh mentioned, I would love every institution, I think, as it relates to pharmacy practice, has a bit of an individual approach, and I would love to take those offline, and maybe we can discuss the unique problems facing each institution separately. But as a whole, I think it's important to note that a traditional medication prescription model is that there's a prescriber-patient relationship that is ongoing, and there are medication orders written for that patient that are then taken to a pharmacy, hospital pharmacy, outpatient pharmacy, Walgreens, whatever, and then filled, verifying that prescriber-patient pharmacist line and relationship. So, the standing order regulation, the 1714.22 regulation, essentially decouples that in a way where you do not actually need an individual physician-patient relationship. And that's actually the intent of the order. And the intent of the regulation itself is to allow for broader access, essentially having a physician, either the state medical officer for the California Department of Public Health or an individual provider at your institution or your organization, write an order that says, my staff, including non-healthcare trained staff, as long as they meet training requirements, are able to distribute this medication, which is notably different than pharmacist furnishing, where the pharmacist essentially acts as the prescriber, or pharmacist dispensing, where you're dispensing in response to a physician order. And so, the individual nuances past that, I would love to speak with anybody. We can discuss what individual institutions may have, but essentially this is a community organization that is distributing naloxone for patients or not, that is operating out of the emergency department in the case of the Highland model or what we have operating here.
Thank you, Curtis. That was much better.
Josh and Kurt, this is Steve Tremaine with Cynosure. I've spent many years dealing with state agencies, and you bring up a really interesting point. When you call a state board or state agency that actually doesn't have jurisdiction over the issue, you're going to often get a very narrow and often incorrect answer. And so I think the point here is what you two have outlined very clearly, is that this is a bypass lane. This is not a board of pharmacy. I mean, it may be, but I mean, this is a bypass lane that's been built. It's not prescribing. It's not furnishing. It's not dispensing. And so it kind of goes outside those laws. So you call somebody at the board of pharmacy, they may be frankly ignorant of what this is all about. So I think it's really important to make sure, as you two pointed out, to know what the question is you want to ask and who you should be asking the question to, or you're going to get the narrow, outdated, often administrative answer. So just a warning.
Yeah, and I will say, at the risk of getting a little too nuanced, which we're hoping to avoid, you know, what we have made an effort to do is to adhere to medication storage requirements. So, you know, having it in a cabinet, in essence, does comply with, you know, storage of dangerous medication as they're deemed by the DEA. And so we do, you know, it is and we do stick to traditional hospital medication requirements. I think that this just falls into a different category as it relates to distributing this product in this individual circumstance.
Yeah, I would mention too that, you know, these are extraordinary times, and this is, you know, in the face of an opioid crisis, you know, this is kind of the context that we're working in. And then, you know, naloxone has no other medications don't have special legislation issued under California law, such as naloxone. So it really has a special category, and this entire program is in a special category. So when you're reaching out to look, you know, for various roadmaps for how to operate, you know, the guidance is unclear. So this is, you know, so if you know, as Steve mentioned, if you're looking to traditional models for them to tell you how to run your program, that's going to be limited. And you really have to look at the standing order, the language of the standing order, and the standing order itself in California law to really guide your program. And that's exactly what we did.
Hey, Josh, this is Amy,
Yes.
and I really appreciate your going through the standing order and all the nuances of that. I actually had a different question. You mentioned that you have all of your staff dispensing naloxone, and I'm just curious how your non-clinical staff responded and what were some of their concerns and kind of how you addressed it.
So, yeah, I mean, you know, it's basically at this point, you know, in a way, we're still in our pilot phase in the sense that the non-clinical staff who are at the front lines of dispensing are our substance use navigators. So they're interfacing directly with, you know, people at highest risk and doing a lot of the dispensing. And it's been sort of person by person. You know, I basically have been recruiting people to sign up and join this program. So it's been completely voluntary. And part of what happened was we started our program right after annual competencies had already gone by. So we missed the opportunity to include the training video in our all staff competencies to just have everyone at our entire institution trained. So it's been a little piecemeal in that regard, but you know, once I've engaged our staff, any you know, staff that has been interested and talked them through the program, people have been incredibly excited about dispensing. So it's been a very positive impact on all categories of people that, you know, basically the ED techs are another, they sit out in the front area, they greet, you know, they're often in charge of greeting patients as they come to the triage area, and they've been very engaged in dispensing as well.
Thanks, Josh. So kind of along those same lines, I have one question from, can a patient be discharged from the hospital, be eligible for free naloxone? I think the point is if you get hospital services, are you also eligible for free services on top of that?
Yeah, you know, it's in a way it's really decoupled from the hospital stay and visit and any bills that are incurred. and triggered by a ER visit. So this project, this is, and that's part of how you create sort of a, it's sort of like this carved out process that has very little to do with that whole process of engaging the healthcare system, incurring charges. And so this just, so yeah, so absolutely. So any patient or their family member at bedside can be dispensed in a very low threshold manner.
The only thing I'd add to that is it's actually in the language of the civil code specifies that the use of the standing order is actually intended not to bill or associate a charge for distribution of the products. Now, I don't know how strict that has been, but also the Naloxone distribution project, if anybody seeks out the grant and seeks a supply to distribute themselves, the conditions of that project also dictate that you actually cannot bill for the product itself.
Yeah, wow. I think what you guys are talking about is you're right, so novel in the way that hospitals are currently run, and just thank you for walking us through this today. But I'd love to hear more about how you dispense to non-patients, the families and visitors.
Yeah, so it's basically, so patients and visitors. So one example is, say you have someone who brought their child in because they have opiate use disorder, and they're at bedside. So what would happen is he would bring a couple of kits, and you would be be sort of educating both the patient and their family at bedside on overdose and response to overdose and the use of naloxone nasal spray, and then dispensing to both parties. For the patient, if it is an active patient in the ED, they will get a note in the electronic health record that they were offered naloxone and overdose and given overdose training, and that can just be a free text note. And then that also helps you comply with the law that that naloxone and overdose training are mandated actually by California law for anyone at risk for overdose. And then of course the people that are going to be able to respond. It's so important to have the people that surround someone with opiate use disorder receiving naloxone kits, so you're able to dispense to that person as well who's at bedside, and then that they just get entered as a separate log event in your log sheet, and you're good to go. And it's a very, very quick and painless process.
Mm-hmm. Yeah, thanks. So we've been talking a lot about the logistical side of making this happen, but I actually kind of want to ask you and Kurt to talk a little bit about your journey and sort of the change management of it all, if you will. How did you get the leaders on board? How did you get the staff on board? What were some of the things you had to kind of address to make it happen?
So yeah, there was a lot of background work in connecting with people within our institution, on our pharmacy team, and people outside of our institution at UCLA and San Francisco General and Rideout, Marysville, UC Davis, really reaching out to a broad group of people who were experts in this area to ensure that we were following the dictates of the standing order, and setting up a process that made sense and was going to have impact and be acceptable to our institution as well. So there was a lot of discussion to do that and sort of bring that to fruition. And then it was a matter of meeting with our nurse managers to ensure that they were comfortable having this in the department, in this program, sort of explaining the program and the purpose of this program. And the nice thing was that as once you kind of get down to brass tacks and are clear that this is a program that will save lives in our community, that's sort of your starting point, and that you're trying to get at that value-added step of take-home naloxone in hand. Once you just clarify that that is the overriding goal, everyone you talk to understands that implicitly, and then you work from there to build out how your program's going to work.
Yeah, and I feel similarly in regards to our process over here. I think Josh and I worked early on, soon after the availability of Naloxone via the grant to kind of establish these programs. And I think what really helped our department was recognition of the need. So I think it's, there are a lot of statistics out there. I think most people, if you spoke to them, would understand that we're in the middle of an epidemic right now. But I think the individual institution need is likely greater than individual providers or administration or nursing staff or whoever actually identifies. And so I found that helpful, really, just to quantify the eligible population that we could be serving with a program like this. And that was really helpful in getting not only the ability to provide it, but also getting buy-in. You need the people who are eligible to distribute the product actually to recognize who's a good candidate and to participate in the process. So the reduction of barriers will increase the value as the participants are able to get the product out there easier.
I think it's worth mentioning too that everyone sort of needs to step out of their comfort zone a little bit. It is there's conflicting regulatory issues and it is just getting at that bottom line that we need to get naloxone. We're in an opioid crisis. We need to get naloxone in the hands of those people at risk. And if you keep on just coming back to that discussion, realizing the state law supports this process, and then you can actually make headway once you kind of get back to the state law, the bottom line issue, and everyone's going to join forces together to make this happen. And that really is a productive way to move forward.
So it sounds like you really were able to use sort of the values that people have in healthcare, right? We want to save lives, we want to help people, and use that as your launching pad for this. Now, my next question is, since I'm also working QI in the hospital setting for many years, my next question is, how long did it take you kind of end to end to really implement this, both from the logistical side and also from the people side?
It actually, it took, it's hard to say. Part of it was, it took a while to feel out this topic. So there was probably almost a year of background exploration of this idea and communications with various people throughout the state of trying to build this program. So there was a lot that took a long time to really understand this law and where it would fit in and how we could actually get this going. Once we actually got to the phase of implementation and receiving, once we got received the naloxone and put it in place and had the cabinet set up, that part was very rapid. So there's so much hand-wringing that goes into the process beforehand and agonizing over this and that. And once we got going, it was so positive, and the uptake and the understanding of the impact was implicit. And so that part actually just flew out the door. Like, it really was a low barrier process once people were seeing the impact it was having on our patients and the response it was getting. It was incredibly popular. So that's kind of the sort of flow that we have. And we're trying to, by offering a lot of these documents and these templates, I'm trying to accelerate, save everyone the sort of torture that we went through trying to develop a process that made sense. So hopefully that will help others.
Oh, thank you, Josh. And thank you for sharing that. I think those of us who are trying to implement new projects get discouraged. So it's really nice to kind of you gave us sort of an expected time frame that it does take a lot of time to lay the groundwork and have those discussions. But once you do that well, and you have the buy-in that you need, then the rest of it kind of falls into place. So that's great. Thanks so much. So now we're kind of, I'd like to transition and move us on to the sort of the wrap-up portion of this webinar. Thank you, Josh and Kurt, for really sharing with us all that you know about this. There's not many people that are doing this, and it looks like together we've worked through how each hospital can do this themselves. So some of the key things that I took away from this presentation were a couple of things. Start off with the value. Get people on board with what resonates with them, and I think most of us that work in healthcare really respond to saving lives. We really do want to care for people, so that seems to work. That seems to be a motivator. 2 is that you gotta get comfortable with uncoupling this naloxone distribution process from your standard work in a hospital. I have to say, working in the hospital setting and working in the quality department, it gave me a little anxiety even just listening to you, Josh and Kurt. And so I can only imagine those in the hospital, how you feel listening to this, but it is possible. And understanding that decoupling this is the way to sort of circumnavigate some of these other rules and regulations out there. Lastly, it's all hands on deck. Everybody is capable of providing naloxone in the hospital setting. And I think that's super cool. And the reason being is I think a lot of this work tends to fall on the provider, tends to fall on the pharmacist. And spreading the love a little bit, if you will, and making this more of a team effort, I think is the way to go. And I think it helps to create a sustained effort. So I know Steve actually has another comment, so I'm turn it over to him.
Thanks, Alex. To me, this, it was so freeing. It felt like the shackles were taken off of all of us who really went into medicine, no matter whether they're a registration clerk or a nurse or a doctor or whatever, a pharmacist. Kind of took the shackles off. I mean, as Josh and Kurt pointed out so much, we're in a crisis. They've created this super highway around the traditional regulations. They've segregated naloxone, so it's not like all other medications. And you know, folks who deal with regulations their whole life kind of have trouble letting go of this. So it's going to be interesting to see what comes out of some of the sidebar conversations that Josh and Kurt have with some of the folks who are getting pushback either internally or externally to do this. But my, how freeing is it that you're at point A, you know what you have to do at point B in order to save lives, and it can be this simple, and it can be this, I mean, you've turned this from a track into a 6-lane highway in 4 months. So to me that, you know, we talk a lot, Alex, about how it's hard to find the joy in medicine sometimes with EMRs and billing and see patients faster and all of this. This is joy in medicine.
I couldn't agree more, Steve. Right, yeah, absolutely. And I think the more that we can collaborate across departments and work together, especially in the hospital system, I think we bring back a little bit more joy every day. So Amy, anything you'd like to add? Other co-facilitator out there?
Yeah, I think when I think about this program, Steve mentioned we talk so much about the barriers, but what always makes it real for me is they allow librarians to dispense naloxone. So as a physician, as a nurse, as someone who's clinically trained, we should be able to dispense naloxone. If a librarian can do it, so can we. And I just bring it all back to that.
So Amy, I have a solution.
Yeah.
For the folks who find that either internally their hospital is stopping them or their system is stopping them, or the way they're interpreting what the Board of Pharmacy is telling them, or the people at the Board of Pharmacy who are not in the know of this regulation, we're going to start a little free lending library across the street, Amy.
I love it. We'll be the free lending library with naloxone. We'll get a couple books. It'll be fantastic.
Great, thanks. So those are some of the key things that all of us as facilitators took away from this. So I'm excited to learn more and hear more about what hospitals are doing on this in the future. So now we're going to move into the final wrap up of this presentation.
Alex, there's a question I think it's important to answer from Sheeta Chan.
Oh.
Is the program going to receive continued funding? And where are we with this? Is this a one and done, or where is the program as far as funding? And I believe she means the supplying, not the law, but the ability to get all this naloxone. Any thoughts, Josh or Kurt?
I do. I think Kurt had to hop off, but yeah. So this is the main thought on that is that part of keeping this grant going is to show demand. So the more applications that enter the system, the more likely that this program will be continued to be funded. So, I mean, I think the other piece is this, the opioid crisis isn't going away tomorrow. So there's going to be likely repeat funding cascades down from the federal level. And then on the state level, as long as there are, showing the demand by having lots of applications, that, signals the state that they need to continue funding these types of programs. So we sort of create our own funding by having applications for these types of programs, and having successful high volume, low threshold programs will demonstrate that this is a very effective use of opioid response funds. So that's, we can sort of create our own funding by having more applications. That being said, it of course is not guaranteed, but that's probably our best mechanism for ensuring future funding is actually by implementing programs.
This is Kurt. I'm actually still on. I totally agree. I feel like this initial program has allowed us to quantify the need in a way that we took stabs at before, but weren't actually able to. The only other thing I would add is that there was recently approved a generic version of the product that most of us are distributing now. And so we anticipate that the cost of the intranasal product, which is the most commonly distributed available naloxone kit, will actually go down. And so the ability to obtain it, the ability for distribution models like ours to continue should actually get easier. And for those places that are distributing the vial for injection, some patients prefer that. It's actually far cheaper anyway. So I agree. I think quantifying the need will help continue the funding and continue grants like the one that's available now.
Thank you both for providing such an excellent answer to that. And Sheeta, thank you for actually posing the question. And for those questions that we weren't able to address in today's webinar and that are included in the chat box, I'll be pulling those out and creating a specific Q&A. I want to make sure all questions are answered. Well, with that said, we have about 2 minutes left in this webinar, so I'd like to kind of move through this wrap-up piece. And thank you again, Josh and Kurt, for sharing your knowledge with us. So next slide. So just a reminder, we have one more webinar in this series. It's scheduled for September 12th, and we're going to be focusing on how you actually measure the impact of what it is that you're doing. There are a number of programs, a number of initiatives, and we're going to unpack that a little bit. And talk about some emerging measures. Another key reminder is that you want to be considered for the Opioid Care Honor Roll, you have to submit your self-assessment by September 18th. There's instructions on our website. I'm available day or night. I'm fully committed to this. It is my life right now, and I want to help as much as I can in streamlining this process for you. Next slide. So in preparation for the next webinar, we'd love to get your input on what it is you might want to focus on. So please take a second and answer this poll. So great. So take a second and let us know what's kind of important to you when talking about measures. So I see some answers coming in. I think there was some thinking going on. Great. So let's end the poll. And I'm not surprised. What people want to know is how you can measure opioid safety using available hospital data. I am with you 100% on that one. So we'll focus on that during the next webinar. Next slide. So just a reminder, all the resources and follow-up materials will be available on our website. That includes the slides, the recording, all the resources that Josh talked about. They're going to be all there for you. Just give us a couple of days to post them after today's webinar. Next slide. Again, if you have any questions, please contact me or Amy or Steve. Next slide. Well, thank you for joining us today. I know taking an hour out of your day means a lot, and I hope that this was a valuable webinar for you. And thank you again to Kurt and Josh. I keep thanking you, but I can't thank you enough. It really was wonderful to be able to unpack how we can all do this together. Well, that concludes our webinar, and we will see you in September. Take care.